All right, let's dive right in. If you're a nursing student tackling sensory neural disorders, you are in exactly the right place. Today, we're doing a clinical crash course on the most common ear disorders you're going to see out there. Let's get to it. First things first, a huge thank you to Dr. Abdul Karim Eblisi for providing all the fantastic material for today's session. Now, it's really important to remember what this is for. Think of this as your high-yield study guide, a tool to help you nail down the key concepts for your exams. It is absolutely not a replacement for showing up to class, getting that hands-on clinical experience, or talking with your instructors. Use this to make that learning stick.
Okay, so before we can jump into what goes wrong with the ear, we've got to be totally solid on how it's supposed to work in the first place. So we're going to kick things off with the ear's main jobs and the basic assessment skills you absolutely have to master.
You know, what's so cool about the ear is that it's a multitasking genius. It's not just for hearing, right? That's its first big job, conducting sound. But it's also home to our balance center, the vestibular system. It works with your eyes and your body's sense of where it is in space to keep you upright. A little problem in the inner ear can literally knock you off your feet. This is one of those skills you'll be doing all the time, so let's get it right. It's all about being safe and effective. You're going to hold that otoscope just like a pencil. And here's the most important part. Brace your hand against the patient's head. Why? Because if they suddenly move, you won't accidentally shove it in too far. Then, just a gentle pull on the outer ear, the auricle, straightens out the canal so you can get a perfect view. Okay, listen up. Screenshot this slide, write it down, do whatever you need to do, because this is pure exam gold. The Weber and Rinne tests are how we figure out what kind of hearing loss someone has. For conductive loss, that's a problem with the outer or middle ear. The Weber test sound goes to the bad ear. And with the Rinne test, bone conduction is louder than air conduction. You need to have this table memorized. It will show up, I promise. All right, let's start our journey through the ear, beginning right at the entrance, the external ear. We're going to look at some super common issues here, some of which are, well, self-inflicted. Earwax, or cerumen, is totally normal, but when it gets packed in there, it can cause pain and that annoying feeling of fullness. The key to managing it is to soften it up first. Some warmed glycerin or mineral oil does the trick. Then it can be removed. But the most important thing for you to teach your patients is at the bottom. Never, ever stick sharp things in your ear. Yes, we're looking at you, cotton swabs and bobby pins.
So here is a classic scenario you've got to know for your exams. How do you tell the difference between swimmer's ear, or otitis externa, and a middle ear infection? There is one dead giveaway. If you pull on the outer ear and the patient just about jumps off the table, you should be thinking otitis externa. That tenderness just isn't there with a middle ear infection. It's a huge clue.
Okay, let's move a little deeper, past the eardrum into that little air-filled space called the middle ear. This is a super common spot for infections, especially in kids, and it can also be affected by trauma. A hole in the eardrum or a perforation can happen from infection pushing out or from trauma pushing in. Now, the good news? Most of these actually heal all by themselves. Your number one job as a nurse here is education. The patient absolutely has to keep water out of that ear while it's healing. We've got to prevent any bacteria from getting into that middle ear space.
It is so important to get the difference between acute and chronic otitis media. Acute is the one you probably think of. It's short-term, it hurts, and there's often pus. Chronic is a whole different beast. It involves tissue damage that's not going to reverse. It might not even hurt, but you'll see this persistent, really foul-smelling drainage. And look at that last point. Chronic OM can lead to something called a cholesteatoma, which is a nasty skin cyst that needs surgery. And now we've arrived at the most intricate part of our tour, the inner ear. This is like the control center. It's where all the delicate parts for both hearing and balance live. And when things go wrong here, it can be seriously disruptive to someone's life.
Let's define a term that patients use constantly, dizziness. Clinically, it's a really broad, general term. It just means a feeling of being off balance, lightheaded, or unsteady. It's a symptom, not a specific diagnosis. Now, vertigo. That's different. Vertigo is specific. The magic phrase you need to remember is illusion of motion. The patient feels like either they are spinning or the room itself is spinning around them. This is not just feeling woozy. It's a very distinct, very real feeling, but false sense of movement. And this slide just lays it out perfectly. Think of dizziness as the big umbrella term for just feeling off. Vertigo is one specific type of dizziness, and it's all about that illusion of motion. So a patient saying, "I feel lightheaded," is describing dizziness. A patient saying, "The room is spinning like a carousel," is describing vertigo. Nailing this down when you're taking their history is absolutely crucial.
When you see Meniere's disease on an exam, I want you to immediately think of this classic triad of symptoms. It's a 3-for-1 deal. You've got hearing loss that comes and goes but slowly gets worse. You've got tinnitus, that ringing or roaring sound. And then you have these episodes of vertigo that are so intense they can be completely debilitating. So we've gone through a ton of problems and diseases. Let's wrap up with what is arguably the most important role you have as a nurse: prevention. How can we actually help our patients protect their hearing and keep them safe? Let's just let this number sink in for a second. According to the World Health Organization, over 1 billion, that's billion with a B, young adults are at risk of permanent, totally avoidable hearing loss. And the main reason? Unsafe listening habits. This is a massive public health issue, and nurses are right on the front lines.
So what's our game plan? It all boils down to education. That damage from noise, it starts happening around 85 to 90 decibels. So our advice has to be simple and direct. Wear earplugs at concerts or if you have a loud job. Turn down the volume. Limit how long you're around loud sounds. And, just like we talked about, take care of earwax the right way and get ear infections treated quickly. These simple things can save someone's hearing for life. So, let's end with a real-world scenario. You're in the clinic. A young patient tells you they love going to concerts, and they always have their earbuds cranked to max volume. As their nurse, what is the single most important piece of advice you can give them to protect their hearing for the rest of their life? Because taking all this knowledge and turning it into simple, powerful patient education, that's where you're going to make all the difference.